Today we're going to be discussing all things vitamin K2, particularly the MK7 variant. And I have a highly experienced PhD, MD, Dr. Hogne Wiek from NATO Pharma, who is an absolute expert in all things vitamin K2. So delighted to meet you here today, Hogne.
And thank you very much for inviting me and giving this opportunity to talk about one of my passions in life, vitamin K2.
Excellent. And I have quite an interest too in vitamin K2. I've done a certain amount of research, but nowhere near your level. And actually, Warren Matthews from Extend Life, I have a relationship with him in the last year discussing all of the beneficial nutrients, vitamins and minerals for human health. And he's incorporating some of your products into his new product line. So it'll be great to discuss all of these and kind of, look at all the data and the support for the level of benefit that vitamin K2 can give to human physiology, avoiding chronic disease, and also acknowledge maybe some of the shortcomings in the data or where more trials might be needed.
Yeah, and that's true, that even if we have come some part away in documentation, it's still a lot more to be discovered around the physiological and health benefits associated with this compound.
Very good, Hogne. So maybe we might start just with a little bit of your background. As you say, this is a passion of yours. So maybe just a summary of where you've come from and where you are now.
So I'm a medical doctor by training, and I've been working as a researcher, as a clinical doctor, and as a professor in medicine at the university in Bergen, Norway for many years. But it came a change around 20 years ago, because then a couple of years was the CEO of the Norwegian Food Research Institute. And at that time, I realized the big importance to let people stay healthy if they want to stay healthy and care for their life and health, instead of just curing people with diseases. So that was a fundamental change in focus. And another thing around the vitamin K2 is that we know that in Norway we have a lot of physical active people. It's possible to have a lot of outdoor activity, just as you have in Australia. But we see that still Norwegian women are more or less on the top when it comes to bone fractions. And that has been a little mystery. Why is this happening when we have all these kind of physical activities for our adult people? And that was also a mystery I was interested in even as a medical student. But at that time, the only treatment or protection was to take increased amount of calcium for people when they grew older. And later on, we know that that was not the best solution alone. And when you then go close to 20 years back, I came over a publication from Japan, where they had made some kind of evaluation of fractions in different parts of Japan. And they ended up to see that in areas where people had still the old way of eating and used the natto food, that is fermented soybeans, it was decreased frequencies of fractions compared to other parts of Japan. And that was the starting point when we later on came in contact with the research environment in the Netherlands and started to make vitamin K2 in the first version commercial available in Norway. And this was in the year 2001.
Right. And absolutely, I've come across several papers around osteoporosis issues and vitamin K2. I guess the classic one that most people associate vitamin K2 with is the reducing or mitigation of arterial calcification. So we might actually talk a little now around the mechanisms of vitamin K2 and how it will improve osteoporotic problems, but also this all-important arterial calcification, given that heart disease is the biggest disease effectively in the world.
As I started, that we just realized that okay, this strange food included some agent that may have impact on the bone density and bone strength. But of course, later on, when the agent ingredients, the vitamin K2, was identified, then we have learned a lot the last 20 years. And just as you say, this vitamin K2 that has a molecular structure that is very similar to vitamin K1. And K1 is a molecule most people know that is injected to children when they are newborn to initiate the coagulation system, to secure that we do not bleed to death. But a molecule that is a little different, has a little longer side chain, has then got the name vitamin K2. And it's a group of molecules with a different length of the side chain. We can talk a little about the characteristic later on. But this vitamin K2 has peripheral mechanistic functional spots. So the K2 molecule activates several of the proteins that are produced in the body. But these molecules need to be carboxylated. They need to be activated if they should have the physiological effect in the body. So for bone, we know that we have bone building cells called osteoblasts. And the osteoblasts, they will secure that we reformulate, rebuild the bone structure on a continuous basis. And if this osteoblast should then produce new bone and then bind calcium, these cells are producing osteocalcin. And the protein osteocalcin, that need to be activated again with vitamin K2 in order to bind calcium to the bone matrix. So that is the one mechanism that vitamin K2, or the form that is most active, the MenaQ7 molecule, will secure that the bone binding or bone building cells can be active. So that is the one thing. And you also then ask about what impact will it have on the cardiovascular aspect. And here we have another protein that is synthesized and generated in the smooth muscle cells in the arterial wall. And again, we know that every day it's a little battle taking place inside our arteries. We know that there are always some small damages coming up, and the body needs to repair these damages so we do not end up with the arteries that are strangulated or too narrow for the blood to pass. So in this repairment process, then when you have the small damages, it ends up that the white blood cells come and try to stop the bleeding or the damage, and the thrombocytes follow up. And then in order to repair everything, to make a solid surface inside the arterial wall, it very often ends up also with calcium to secure that everything is solid. But then we can't stay with too much calcium inside our arteries, because that makes more stiff arteries, and that increases also risk for high blood pressure. So here comes again the small molecule called matrix GLA protein. And this GLA protein need to be activated to be active, take away calcium. And again, here comes vitamin K2. So K2 will activate matrix GLA protein, secure that we smooth the surface of the previous damaged arterial wall, and then we will have a soft and normal arterial wall after the healing process is finished.
Right, and matrix GLA protein does appear to be the key mechanism that connects vitamin K2 to our arterial health. And I know there's some really fascinating animal experiments where they actually suppressed the protein, or they greatly depleted the animals in K2, and they generate enormous amounts of calcification. kind of out of control, and lots of other markers going in the wrong direction too. Do you think that beyond the matrix GLA mechanism, which we'll talk about some more in the human studies, that K2 is delivering other health benefits through other pathways beyond the matrix GLA one, which is more well known?
I'm absolutely sure that it's a lot more to be found of these mechanisms. But it's, I guess that also for the human body, everything is connected with everything. And the more we learn about mechanisms in the body, you see that we are going down into micro elements that are so fundamentally important for all normal biological functions that you can choose to be an astronaut to look out in the huge world outside, or go down in the microcosmos in our body, and it's fascinating both ways. But for vitamin K2, we know for sure that it's around 20 different proteins in the body that is activated by vitamin K2, MK7, and these protein has different functions. But now we have started to see at a very important thing around the calcium paradox, because it's more or less so connected that vitamin K2 can secure that the amount of calcium we have in the body and the amount of calcium we have in our diet will then stay the right places and go to the right places. Because if we do not have enough vitamin K2, we end up to lose calcium from the bone matrix. And then, as you said in the beginning, we can develop osteopenia and osteoporosis. And we have a lot of examples that we see just walking around in our local village, that it's a lot of people suffering from that. But if we then do not have vitamin K2, we develop osteopenia when you get older. And you also store the calcium in the endothelium layer in the arteries, because this is one of the mistakes made by God in the past, because that seems to be the only place where we can store calcium. And that is why it ends up with the stiffening of the arterial wall. So therefore, the osteocalcin is important to let calcium stay in the bone matrix. And matrix GLA protein is important to secure that it's not stored calcium in the arterial wall. So this is the most important area, and new areas will definitely be discovered later on. I can talk a little about the other things, but these are the two main important functions of vitamin K.
Right. Well, then that's probably a good point to maybe talk a little around the epidemiology. I always see epidemiological data as being kind of the weakest because it can be confounded. Then there's mechanistic data and animal studies, and then there's the actual human trials, which are probably the most convincing. So the epidemiology, the Rotterdam study is probably the most well-known example. So maybe run through what was seen there. And it was quite striking because vitamin K1 did not really have any linkage to the various health parameters, whereas vitamin K2 quite dramatically did have a linkage. So there was less confounding there in a sense, because the K1 showed up no signal and the K2 specifically showed up a pretty strong signal. So maybe talk a little through that study.
Yeah, that is very interesting observations. And also it's rather good description from especially the Dutch population, because that country is known for their tulips, but also for their very tasteful and strong cheeses. And we know that that vitamin K2 can be found in this Japanese food, this fermented soybeans, as I talked about, but also in fermented dairy products, as strong smelling and strong tasting cheeses. And that means that in the Netherlands, they have perhaps a higher normal intake in their diet of vitamin K2 containing food than in other countries. So the Rotterdam study, they was just then asking people what they are eating, and then they grouped the people after the amount of vitamin K2, the MK7 molecule, expected to be in the food they were taking. And the striking observations were that if people had less than 23 microgram of vitamin K2 in their daily diet, that was the group with the lowest intake. And they had the other group with 32 microgram or higher intake of vitamin K2 in the diet. And then they looked into these groups over a 10-year period and followed then the incidences of cardiovascular diseases, of myocardial infarction, and of cardiovascular death. And the striking finding was that it was a 50% difference in myocardial infarction between the two groups. And when you looked into the death, the difference in death frequency, it was a 50% difference again. And since cardiovascular death is 50% of total mortality in the Western world, it was then a total difference of 25% in total mortality, just linked to this one single unit, more than 32 microgram vitamin K2 or less than 23 microgram vitamin K2 in your daily diet.
Yeah, and it was pretty powerful for epidemiology because often I love the example of poor epidemiology is the WHO recommendation that perhaps meat causes cancer, and that's based approximately at an 8% difference in the incidence of cancer, which is a tiny hazard ratio and is lost probably in healthy user bias. Because people who ignore the advice for the last 4 decades to eat less meat, those people are going to be healthier type people. But this one is great because no one has been advising really on what to eat. And yet you've got a 50%, or if you look at the other way, a 2x or 2 times hazard ratio. And that's kind of accepted in epidemiology. If you double your risk by being in a certain category, that's a strong hazard ratio. And that's very unlikely to be confounded or by chance generally. So I think it was a very interesting study. Do you think that is what helped then propel more research and work on vitamin K2? Did it wake the world up?
I said I've been interested in these topics for the last 20 years. And I should love to say that this really made the world open their eyes and see this was important. But I have to say that I have been more or less a religion preacher of this message for the last decade or more, and it's still a lot to be done. So in some areas, people have a certain knowledge about vitamin K2, but for most people, even if they are very focused on health, it sounds like news. They hear it for the first time. But I've also been working with omega-3, and we know that omega-3 was more or less on the health map in the late 60s. And if we say that vitamin K2 are 30 years behind, then we need to be patient. But I think definitely that the observations we have, and this Rotterdam study was the starting point for making more interventional research. When you wait for another 20 years, or hopefully before, more people should take the health benefits and advantages by using vitamin K2 on a regular basis.
Yeah, I'd certainly agree because the body of evidence, you never have perfect 100% proof, but we'll talk through some of it. When you add it all up, the mechanistic, the animal studies, the human studies, certainly the epidemiology is consistent. You've got a large body of evidence overall, and one shouldn't wait, like you say, until the perfect study is done. So on the animal studies perhaps next, there's some really fascinating ones out there, and a lot of them were done a reasonable amount of time ago, where they had vitamin K antagonists and they caused runaway calcification. And not just calcification, but also a negative vector for other health markers and inflammatory markers. So maybe your thoughts on some of the key animal study data and what it tells you.
For some of these animal studies, and you are right, most of them have been done around a decade ago. We have seen that when you look into calcification of the smooth muscle cells in the arteries, and that was also human smooth muscle cells in culture, you can see that by using vitamin K2, we can inhibit the calcification quite remarkable compared to a control group where you didn't have that kind of vitamin K2. So that was one group of in vitro studies. You also have special models, as you mentioned earlier, where you have animals where they do not have the normal anti-calcification enzymes in the body. And again, you see that they calcify the arteries and die very early if you do not have some antibodies against that. And again, vitamin K2 could inhibit the speed of calcification of arteries. So that was the starting point from the Rotterdam observation. That was more or less an epidemiological observation to interventions in vitro models and animals. And again, and that has a little to do with coincidences, but in the Netherlands at the university in Maastricht, they started up a brand new university in the mid-70s, and one of the guys that were invited to start within biochemistry and medical research there was Professor Kees Vermeer. And he was the one starting up with specific research around vitamin K2 early. And NATO Pharma, and even before NATO Pharma was founded in 2004, I picked up some of the research done there. And Professor Kees Vermeer, he was invited by me to Norway the first time in 2001 to give a speech around that. And later on, it has been a long collaboration that still continues between the university in Maastricht and NATO Pharma in Norway. And based on this collaboration, we then understood that from a commercial perspective, it is not enough with good animal studies. You need to have data from humans. And that started up with some interactions and interventional studies where we then used to give people vitamin K2 for a limited period of time, 8 weeks, 3 months, and then looked into the activation of the proteins that we talked about, ovostocalcin and matrix GLA protein. And not of course, but we saw that the activation were mandatory and has had a big impact on the ratio between non-active and active or carboxylated proteins. So that was the first step to see that, yes, this compound had the physiological impact on the protein in the circulation. But the next step was to see if we could even measure differences in the calcium loading in healthy people over time. And if you allow me to say a little about this study, because that is to run a clinical observation for a 3-year period is extremely demanding, and to follow people for that long time when they do not have a disease also means that you need to really to care about the test people you include. And vitamin K2 or the products sold by NATO Pharma that we then distribute also to Australia is then not the drug. It's something that we promote and ask healthy people to use to prevent development of diseases. So therefore also the clinical trials need to be done in healthy people and see if they can stay more healthy if they use vitamin K2 compared to if they do not use it. So therefore, I think it's even more challenging to show that a healthy person is more healthy than to show that the diseased person may recover. Do you agree?
Yeah, it is very challenging, and I'm looking at many different kind of vitamins and minerals at the moment, and that is a challenge. They often use healthy people, and if people are very healthy and relatively young, it is that much harder to see the benefits in shortish trials, and sometimes as well with components. There is a low limit set to the dosage because of safety, and therefore you're getting a low dose in a very healthy younger person. It's harder to see the beneficial effect. So yeah, I agree.
So with that starting point, we then designed a clinical trial in healthy women, and we picked women where they had been without menstruation for at least 1 year, because then we know from normal physiology that then that is the period where they lose most calcium and most bone strength over every year after that age, around 50, 55. And then we picked then a group with around 120 people that were given 180 microgram of vitamin K2 every day for 3 years. And the other group had a placebo capsule looking just the same every day for 3 years. And this was done in the clinical upset as if you are testing drugs, pharmaceutical drugs, a randomized double-blinded trial, so nobody knew what was happening. And then they came in every 3 months to have a refill box that we could see that they have taken the capsules, and they talked to the study nurse, and it was taken then an X-ray or DEXA evaluation of their bone density at the starting point of the 1 year, of the 2 years, and of the 3 years. So that was one part of the study, and I can talk about that first, because here you saw that in the placebo group, we had the expected normal loss of bone strength and calcium content in the bone, that it was a little decrease after 1 year, more after 2 years, and then even more after 3 years. So it was about loss of 1% of the calcium content every year. In the group that got 180 microgram of vitamin K2, the MenaQ7 molecule every day, we reduced then this loss with 70%. So that means that instead of losing, say, if you lost 3 grams in the placebo group after 3 years, you lost only 200 microgram, 300 microgram after 3 years in the vitamin K2 group. And these differences are huge.
Yeah, that is a huge drop, because even a 20% relative change in a parameter for an intervention, as you say, in a proper trial, that's sizable. And often there are medications that shift things by 20%, and it's seen as a huge success. So 70% is pretty enormous. I mean, it's not a mile off complete eradication of the bone loss, calcium loss.
Mm. And this is also, if you then, and of course this is done in healthy people. So we can't say that we can reverse these kind of processes. We don't know exactly what is happening if you already have developed osteoporosis. We don't know how this will interact with if people are already on other drugs to inhibit or treat osteoporosis. But it's just a strong signal, and I guess from the current situation, it should be a good advice to say that people, if they expect to live until they are 90 years of age, then by using vitamin K2 in these dosages, it's very likely that they can stay until they are 90 or 100 with no osteoporosis problems. If we can postpone osteoporosis with 20 years, that could be a big gift to people that are concerned about health.
Absolutely, and it's a very big problem in the world, no doubt. And we have got an aging population now, increasingly, so it's all the more important. And a lot of people as well want to maintain their strength and vitality into their retirement and to older age. A huge proportion of people. So they need to be thinking about all the things they need for that. And, magnesium, a lot of other minerals and vitamins are important too. But this one really talks to the heart of osteoporosis, in fairness, it would appear. I think there was another trial done, or the same group, where arterial stiffness was looked at. Was that the same?
We can take that as the other part, because when you have people that are followed over so long period, of course, we also looked into the cardiovascular part of the body. And again, if you should do observational things, X-ray was a well-recognized methodology. The DEXA methodology was okay, especially when you had the same nurse taking care of the study for the all 3 years. When you go to looking into arterial stiffness, it's a methodology called pulse wave velocity. That is also a very well recognized medical test, and it's a non-interventional test, meaning that you use the ultrasound signal and see how long time will it take from this signal to move from one surface of an artery to another endpoint. So then, and we know that if you have a very stiff pipe or a stiff artery, then the ultrasound signal will then go fast along the wall. And if you have a flexible and more normal arterial wall, then the signal will go slower. So normally, if you are aging, then we see that the value, the speed of this signal per second is increasing. So when you are 20 and young and in love and all these kind of things, then the speed is low. Then it can be 8 meters per second. And when you get with gray hair and some stiff arteries, then the speed may be 12 meters per second. So therefore, the medical environment, they have said that, okay, this speed is a signal of what is physiological conditions of your arteries. So that was the test method we used. And again, we measured these 240 people, the women, at the starting point after 1 year, after 2 years, and after 3 years. And we ended up to then compare the effect or the speed of pulse or the pulse wave velocity, comparing the starting point and after 3 years, because here it was not so significant differences. But after 3 years, it was a significant difference. So we saw that the speed in the placebo group increased as expected. So it increased with around 1.5 to 0.5 to 1 meter per second after this 3-year period. And we had hoped that we should then be able to reduce that speed increase in the vitamin K2 group. But in fact, what we saw was that the speed decreased. So that meant that this was a significant difference from zero, that after 3 years, this pulse wave velocity, the speed of the signal, was slower than after when they started. So that means that these women had then, in fact, younger arteries after 3 years than when the study started.
Yeah, and I remember getting that paper, that study, actually, Hogne, but I didn't know at the time anyone who was involved in it, so I'm delighted to be meeting you now. But I remember being very impressed because, as you say, and from memory, not just statistically significantly lower speeds than placebo, but actually crossing the zero line and being significantly negative or improving. So that's human data, as you said, double-blind, placebo-controlled pharmaceutical trial standard, and a very significant result with a very meaningful shift in both the osteoporosis improving and in the pulse wave velocity or the arterial suppleness, softness, actually improving when it should be getting worse. So that's really powerful data.
Yeah, I'm sorry, I'm a little too eager here, but that is.
No, that's good.
But we have, and to be allowed to use this description and documentation in Europe, the EFSA, that is the body that can approve medical claims in Europe, they said, okay, you need to have not only one clinical trial, you need to have one more that can duplicate your results if you should be allowed to talk about these things. So therefore, NATO Pharma then also have run one more trial to look into potential changes in pulse wave velocity. And that study was finished less than a year ago, and the publication hasn't been public yet. But that then we followed again 240 people. Now we also included men, because we would like to use this product not only for women. I think also you and I deserve to use it and have some data for men. And there we picked then healthy men and women. But the inclusion criteria was that they had quite a high level of non-active matrix GLA protein. That has now been defined as a risk factor to develop cardiovascular diseases. So now we had the value that they were more than 970 of units for this matrix GLA protein measured in the blood circulation. And then we again have a double-blinded placebo-controlled trial, 120 people in one group and 120 in the group getting 180 microgram. And after 1 year, we saw that in the group that got 180 microgram MenaQ7, it was the same speed. It was not decreased, but it stayed at the same speed after 1 year. But in the group that got placebo, it increased as expected. So even if this was not a 3-year study, it was following up on the same kind of mechanism that we were able to inhibit that increase calcification and increase stiffness of the arterial wall.
Right. So, and you had effectively duplicated, which is what the authorities require, just in case. You know, it's a fair thing to ask, I guess, because there is a huge problem in the world of science now with replication of results, especially, I believe, in cancer trials. Like, there's a massive amount of stuff not getting replicated when they go back again. So that's great that you're able to tick that box. And the 180 microgram is a very common figure one hears. And I think, again, extend life, that's the standard amount in their new product, CX8. But one would wonder, would higher doses perhaps give a bigger effect size? Or is there a tendency to avoid wanting to go higher or play safe? Or
yeah, so from the safety aspect, if you have been a Japanese guy and took this natto food, then one daily serving represents 900 microgram MenaQ7 molecule in average. So therefore 180 is far below what has been good for normal diet in Japan. The reason why we picked 180 is based on a dose ranging study, just as you do for pharmaceutical dose ranging tests, that we gave 10 individuals. First, one group got 20 microgram for 8 weeks. One group got the double, 40, then 80, and then we doubled the dosage. And then we could see after 8 weeks that then with 180 microgram, we had then carboxylated 80% of the osteocalcin. And if we double the dosage to 360 in the healthy population, it was very small increase in activation. So therefore, we had come to the plateau and then it flattened out. But if we then go into people that are not healthy and 20 years of age, it may be that we need a little more than 180. But that is what remains to be done, because now it's ongoing clinical trials in patients that has been through their first myocardial infarction. And there are studies ongoing with a daily dosage of 360 microgram MK7 every day. And the hypothesis is that if they have this kind of daily intake of vitamin K2, you will prolong the time from the first myocardial infarction to the next one. So then these data should be available hopefully already this year. And that may be the first scientific data saying something about if this is a complementary treatment to cardiovascular diseases. I hope so, but I don't know yet.
Yeah, well, I think I've come across that one all right at All Trials or trials.gov, I think, when I was searching. And like you say, I think it's not too far away, the result. There may also be one, or it may be the same trial where they're going to look at calcification at the start and calcification at the end and look for a slowing of the calcification. But if there's actual endpoints like cardiovascular events, all the better. So the beauty is as well, I think I agree with you that because of the cheese and the natto in Japan, the upper bound, of course, is going to be really high before there's any negative effect. But I think the authorities they're so risk averse. I'm guessing that there's a tendency to pressure really as low as possible to avoid any question. I think that's just generally the way with vitamin D as well. They used to hold to 600 micro units for decades, when arguably the data shows 15,000 a day is highly unlikely to have a negative impact. But yeah. So
I can just comment a little upon that, because for the safety elements, then this story from the natto food in Japan has been accepted as a dose explanation, both from EFSA in Europe when you go to the novel food approval, and also when you had the GRAS approval in US, when regulatory authorities just look into the safety aspect around it. But going for a drug, I guess you are completely right that, and there are activities now trying to make vitamin K2 also as a drug in higher dosages for special medical indications. But then you are right that then you need, it's even tougher requirements to show that this is the effective, lowest dose effective for that kind of condition.
Yeah, and actually a last thing on dosing as well. I'm kind of thinking you did the work, it sounds excellent, where you looked for the plateau or the diminishing returns for increased dose, and that's a great way to kind of zone in on an initial dose to try in trials. But that was using the matrix GLA protein, the carboxylation, but there may be other effects of K2, as we referred to earlier, not fully worked out yet, where higher doses may be more benefit. But I guess there's so much work that would need to be done to close all this out. We'll just have to wait for that.
I guess that there are already come out publication around where K2 seems to have an impact on inhibiting development of diabetes type 2. It seems to have an impact on apoptosis, on fat cells, and that can have an impact on development of metabolic syndrome as a part of this diabetes development. There are discussions around impact on development of Alzheimer, dementia, not only with the blood flow and vascularization of the brain, but also when you go to contact between the different nervous cells in the brain. So, but it's so big difference between the quality and amount of knowledge we have of these potential mechanisms compared to what we have talked about around calcium and bone and the cardiovascular system. So that is why I'm rather hesitant to talk about the other things, but it just point to the fact that if somebody will be fascinated at least 50% as much as I am, then there should be a lot of new science and interesting things to uncover in around vitamin K2 in the time to come.
Yeah, I would certainly expect so. And on those latter things, I mean, insulin resistance, type 2 diabetes, Alzheimer's being referred to now occasionally as type 3 diabetes or insulin resistance of the brain. And it's arguable that most heart disease links intimately to diabetic dysfunction. So I like the way all of these processes are intimately connected. So it's not too surprising that K2 could have many forms of action throughout the whole system, because that's often how evolution works. I might ask though one thing on MK7 versus MK4. And there's some debate online about this. And I mean, some of the things are that MK7 has a much longer half life and can be more effective. That's the tendency from what I've read, where I'd be going. But you'd be a great person to talk about that briefly.
No, but MK4 was approved as a drug in Japan many years ago, 15 years ago, but it was no success. And even if the mechanisms for MK4 around cardiovascular diseases and osteoporosis should be the same, then the stability of the product was one problem. And the other thing is that relatively low half-life, meaning that if you took a capsule in much higher dosages than we use for MK7, then you need to have a refill quite frequent in order to have a good stable concentration in your bloodstream. And then again, when this should be a drug in the area, as we talked about bone and especially bone, then other drugs popped up that were more efficient. So therefore, it died out. And MK4 has never been a very good ingredients as a drug. MK7 has a longer half-life. The maximum absorption is around 6 hours after you have taken the capsule. And even after 72 hours, after one capsule, you will have around 10-20% of the initial maximum concentration in the bloodstream, meaning that some of the molecules are circulate in the circulation for a long time. And as long as we have MK7 molecules in the circulation, it means that they are more or less a small engines that are, when they meet some of the proteins, they help the protein and activate, and they go around to the next protein. So it is working, physiologically working all the time. So this is why not only NATO Pharma, but also other suppliers of vitamin K2 now stick to MK7, the MK7 molecule, and they have it in the pure form. I can say a little about that even the MK7 molecules have different quality, because in the nature we have what is called 100% trans MK7 molecules. That is because the binding of the side chain is in a special binding, so that the three-dimensional structure of the molecule will be so that it fits in and binds to these areas, so it will have a physiological activity. If you have the binding called cis, then the three-dimensional structure of the molecule will be different, and then it will be inactive. So then to have a MK7 molecule that is all trans is important. The other thing is if you make the molecule in nature, and then you have different fermentation processes, and you have to purify and take out the molecule, then you can end up with providers that have a very pure substance to sell you. And I guess the best pure natural substances are around 96-97% pure, but you can end up to buy more the crude material with purity that can be below 50%. And in the marketplace, we then end up with a little battle where people sell vitamin K2, MK7, and in fact they do not sell the same product. So this is for all consumers. Be aware that that MK7 is not MK7. You need to trust the company behind it, and see if this is a company that you can recognize, you can track back to where they come from, and you see a little if this is a sustainable company or if they will just like to earn some fast money.
Yeah, that's a great point, Hogne, because, and also a company that has a PhD, MD, medical director with a 20-year passion for the product probably helps as well, right?
It's a passion may be good, but it can be a little dangerous. So I'm not at all totally objective in this area, but I
Yeah.
think it's important that we talk with data we have, and that
Yeah.
we do not mix speculation with documentation.
Yeah, exactly. But it is a really important point about quality, and I've learned that from discussions with Warren. He's explained to me the entero coating processes and microencapsulation and purity coming cheap products that come out that sometimes are degraded within days or months before you even open a packet. So there's a lot of kind of sharp practice, we call it, out there, I'd say. So people really need dependable sources when you're getting important vitamins or minerals and you're taking them as part of your longevity or health maintenance strategy. The last thing you want is to be taking something that's almost like a placebo.
Yeah, yeah,
Yeah.
correct.
So we might actually, and I'm conscious of your time, but we might close with just a little bit of the further back history, without going into too much detail. I was fascinated by Weston Price, and that he actually identified a component that gave great evolutionary health to certain populations. And even I think he tied it down to the lush spring grasses, when this component seemed to be very available in the foods, and he called it, I think, Activator X. And it was fascinating that it was maybe many, many decades later that I identified this as K2. So maybe, yeah, what that's a fascinating story, isn't it? And it also shows the lineage of K2, that it's not just something we discovered and it looks like it's beneficial and there's all these other mechanisms and now trials, but its lineage goes back to the 20s, where Weston Price, who's quite a brilliant man by all accounts, identified something and didn't even know what it was, but just knew it was really important for health.
Mm-hmm. And then to comment upon that is that if we in the medical environment today think that we just find genuine new things, we have to rethink, because it's so many good observation in the past, and it's really true, as you say, that if people find something they do not understand, if they can bring that forward, and later on perhaps we can have other tools and discuss and understand a little more what they found in the past, that will help us. And this when I was working in pharmaceutical industry in the 90s, then that was the time when pharmaceutical companies were trying to make up new molecules all the time and hope that these molecules will have some kind of medical effects. Now we are more and more thinking that we would like to learn from nature. What is happening when we eat, what are found in different vegetables, fruits, and so on. And this vitamin K2 is a perfect example, that then we understand some of these old observations in a new way. To complicate it a little more is that in our body we have more bacteria than we have cells. So there are billions of bacteria in our body that, and most of them do a very good job. We are dependent upon them. And some of these bacteria also produce vitamin K2, MK7. The problem is that most of these bacteria are located in the distal part of the colon, of our digestion system, meaning that what they produce of this vitamin K2 is literally going down the drain. So the body can't take advantage of it. So, but in some situation we find that it's also some people with high concentrations of vitamin K2 in the bloodstream, in the saliva, in other biological solvents, and we don't know exactly, and we don't understand why these people have these high concentrations when they do not eat the right food at all. So it's still a lot of new things to understand. And when you talked about this observation in the 20s and in the 40s, then it was more a dentist talking about that K2 may be important for your tooth and for your teeth. And that was his entrance to this. So maybe it's a lot of maybe it's some of the cellular things, some environment for the bacteria that make them not to be able to be a factory for K2 in our body. It's a lot of new things that it should be interesting to follow in the year to come.
Yeah, for sure, Hogne. Or even as well, if K2, as we touched on earlier, could be important in many different ways for systemic health, then there may be knock-on pathways to the dental system and development, or as you say, maybe K2 concentration in saliva. So a lot to look forward to in the coming years. K2 is just one of, I have a list of around 6 or 7 or 8 kind of key vitamins and minerals, and K2 is right in there. And I'm really looking forward to see all the data emerge. And hopefully the modern system, which is currently really locked into pharmaceuticals to address often symptoms rather than root causes. And I love the idea we can get back to purified products, which are more resolving the root causes or giving us the right nutrition that human physiology should have always had in evolution. So I think it's very elegant, and I really enjoyed this conversation. Hogne, have you any last thoughts to add in?
One little thing is that when we are eating cheese, then we do not get only one vitamin and one fatty acid, but quite a mixture of things. And I guess, as I said, vitamin K2 is also a family of different MK7 molecules. So it may be that the mixture of different MK molecules, MK4 plus MK7 plus MK9, is the way nature meant us to absorb and eat vitamin K. The same way as when we eat fish oil, we can have EPA, DHA in a concentrated form, but in the nature, it may be even better to eat fish, including also some other fatty acids. So that is an open question in the end, just saying that it's extremely good to know about the effect of one defined component, but to eat healthy and to have variation in your diet and laugh a lot and have a fun life, that helps a lot for a good life as well.
Absolutely agreed. And I think that's great. Get a really good diet, reduce the processed carbohydrates and processed foods, and eat as much nutrient dense food as you can. And also, especially for people who have, say, a high calcium score or other demonstrated issues, particularly to make sure you get some key molecules in there on top of that. Or anyone who's really focused on high fitness and longevity and really enjoying the retirement, right?
That's right. That's right.
Well, thanks very much, Hogne, and we might talk again as these results come out down the road sometime, but this has been really great. Thank you.
Thank you very much. Thank you.
Yeah.